Thanks so much for joining us this morning. It is a real pleasure to be able to welcome you to the final Social Market Foundation panel event of the conference season. I think we've saved the best for last. I think this is one that we're really looking forward to. Great panel, great topic. So we're really pleased to be bringing you this discussion on whether there is a distinctively conservative approach to public service reform in partnership with the UCL Policy Lab. A few bits of housekeeping before we get going. No fire drill expected. If you do hear a fire alarm, follow that green guy. He looks like he knows what he's doing. There's those signs out all the way through. If you are on Twitter/X, we're at SMF Think Tank, UCL Policy Lab, or at UCL Policy Lab, and the hashtag is #CPC24. For those of you who don't know me, my name is Aveek Bhattacharya. I am Research Director of the Social Market Foundation, and for those of you who don't know the Social Market Foundation, we're a cross-party think tank based in Westminster to get a sense of the sort of work that we do and our think tank brethren. I would encourage you to sign up to Wonk Week, which is our weekly summary of the best research in SW1 and beyond. But really, one of the topics that we as an organisation have been interested in for I think the better part of 3 decades, most of our existence, is the idea of public service reform. And public service reform is a rather slippery concept. I think for people of a certain vintage, public service reform is essentially a sort of euphemism for marketization, for choice in education, for private sector involvement in healthcare, for that sort of agenda. And then I think in the last 10 or 15 years, it seems to have got more ambiguous, if anything, and has kind of landed up to something of a bit of a black box, essentially, whereby we put in less resources and we get better output. And it's kind of some more cynical wags have referred to the idea of the reform fairy as something you can say if you're a politician that will get you to better outcomes for less money. I think over the course of this, we'll be talking, I think, probably with a bit more traction on the left. There's been a bit of a reaction and a bit of a shift towards what we might call relational public services, which I believe Gabriella is going to talk us through to some extent. And then there's kind of the question of, well, is there more to be done from the old playbook, or are there other ways forward? So I'm really keen to have this discussion to put some flesh on the bones of the concept of public service reform and to see where does this fit into conservative ideology and the direction of the Conservative Party, given that that black box is alluring for a reason. It's pretty tempting to get more for our money, and certainly given productivity, there's good reasons why we should be expecting kind of more for our money for public services. So I'll introduce the speakers as we move along, kind of start from our right and then work my way along as we go. So I'm going to start with Professor Gabriella Conti from University College London, who specialises in health economics, early intervention. It's going to tell us a bit about how we should think about public service reform.
Yeah, thanks very much. Good morning, everyone. Thanks so much for being here. I know we have some tough competition in the other room, so we really appreciate your presence. And thanks for inviting me to this panel. So it's clear that we are a very critical moment. The life expenditure are high and the health of the population is not improving. If anything, health inequalities are increasing. And I'm being tasked to say what a more relational and community-led approach would look like in the context of public health reform. So first, let's have a look at what the science says. What makes people healthy? Why are some people healthier than others? And there is a very robust research from a variety of disciplines showing that what happens in the early years of life, so things like early environment, nurturing, parenting, secure attachment matters for health across the life course just as much as nutrition and healthcare. And in one of the first studies that I did on the topic, that I studied the origin of health inequalities in the United Kingdom, we showed that up to half of health inequalities in adults really matters, and it's also been shown that a preventive developmental approach to the reduction of health inequalities works. It's good social policy, but also fiscal conservatism. What has been happening instead in face of the science from the side of the policy? Well, we all know there have been, I would say, vicious cycles of budget cuts, short-termism, and silo thinking. There have been cuts to prevention, cuts to public health, and an increase in the amount of expenditure put on what I would call acute care treatment, not prevention. So why don't we start thinking, instead of health expenditure, investment in health, which is ultimately an investment in our economy, in our society. And there is more to prevention than just hospital care, and even there is more to prevention than primary care and GPs. We need to think about the really prevention in terms of what happens in the community. So there are for professional figures like special community public health nurses and visitors and school nurses whose numbers have been slashed continuously. We've been collecting freedom of information request data on these professionals because there is no public data set which allows us to see what happens at the local community level. And in a study which will be out soon, we'll be looking at what happens in terms of not only health visitors numbers, but composition of the teams across sites, changes in the type of professionals composing these teams, caseloads, and the like. So what a more relational and community-led approach to public health reform would look like. So first, it would be a change from a transactional type of approach where you just get services from a provider to more relational, where you actually have a continuous exchange between users and providers, and there are more sustained long-term relationships. There is more continuity of care. There is co-production with community, not just top-down approaches. It's a more integrated approach. So if you want to tackle health, you need to tackle the whole environment, the social determinants, which means the healthcare system needs to talk to the education system, the housing system, the employment system, and that's easier and more efficient to do it locally. And then there needs to be a focus with this approach from a reactionist approach, or you just react when there is an acute episode, to prevention and early intervention with sort of like integrated, personalized, context-specific solutions which are more likely to work, because we know that one size fits all doesn't really cut it. So what is the good news? This is actually could be a conservative approach in the sense that first, it's not top-down state of bureaucracy. It empowers local community, can foster community resilience, and ultimately reduce state dependency. It can increase community engagement and so resilience. It puts emphasis on personal responsibilities because we all need to take care and take responsibility for our own well-being. And because there is a focus on prevention and early intervention, there is potential for cost savings down the line. Now, this is not utopian thinking. There are actually examples of this approach a lot in England, in many different local authorities, but also abroad. So when I was in the United States, spent many years at the University of Chicago working with the Nobel Prize winner, we showed the importance of investing in the early years of life. And we were working on small-scale trials where you give a lot of resources to more disadvantaged children, either in terms of enrich the free child care or in terms of intensive home visiting by highly qualified nurses. Those interventions worked. But the key question was, can you do it at scale? Can you do it in a system where there is universal health care? Well, the answer was here. So the first year thing I did when I came to the United Kingdom more than 10 years ago, I studied a program where services for parents of under 5s were all put together in one place, which was easily accessible. And there were parenting services, stay and play, signposting, referral even to job services, and all support that parents of under 5 would need. We evaluated this program and we showed that if you were exposed to this program at 0-5, you would have health improvements up to adolescence with up to 13,000 hospitalizations per year reduced for one more center per 1,000 children in the adolescent year. So I guess you've all guessed it, this program was Sure Start. And Sure Start was actually a community development approach. There are others, and now there are others across England. There is Better Start sites. There is a program called Thrive at 5 that I'm also contributing in the evaluation, up to the Start for Life and Family Hubs, which we know are much less funded than Sure Start was. So this approach might work, but of course there are some risks. What are the risks? First, you will need a significant upfront investment. Some communities might be more disadvantaged than others. So if you don't do things right, you could create more inequalities and you can worsen the already existing possible lottery. So what can you actually do? then I will say you need to provide equitable funding allocation. Why don't we come back to 2016 APRA formula, the formula Advisory Committee Resource Allocation, where you need more money depending on funding, increase the size of the public health grant and make it a multi-year settlement so that you give a big push. You need to have, I believe, national standards, but there must be some local flexibility, but you need to be able to monitor performance and have accountability, which means you need to have a good integrated data system at local level. This only exists in some sites now. And last but not least, I'm a huge believer in the importance of the workforce. Recruiting, training, retaining the workforce is key, and I have a lot of research on this point because ultimately the quality of the services, a lot of that boils down to the people who deliver them. So the question that we have today is not whether we can afford to embrace this approach, is whether we can afford not to. And ultimately, as I said, it's investment in our health, in our well-being, and in our economy. Thank you.
Thanks, Gabriella. I'm now going to bring in Neil O'Brien, who's MP for Harborough, Oadby and Wigston. Was Public Health Minister, was Minister in the Treasury, is, as would be expected from one of our brethren think tank alumni, one of the more thoughtful and informed MPs, and author of an excellent recent essay on different forms of public service reform.
Well, thank you. And I can see even from the room that there are people from lots of different public services here. There are some local government leaders, there are DHSC people, there's people with lots of different interests. So it's an impossibly massive question. I think there are, broadly speaking, two different types of public service reform. There are types of reform where you try and drive improvements from the centre, and then there are types where you try and create a self-improving system. So if I can use health again as a sort of example, when I was health minister, we were driving some improvements from the centre. We put money and technology in the hands of GPs so that they could manage more demand online. We've got more happening through the NHS app. We are completing the rollout of electronic patient records in hospitals and electronic bed management, sort of technology we drive from the centre. We pushed new modes of delivery. We created a thing called Pharmacy First, for example, where you can go to your pharmacist for a lot of low-level health conditions, so you don't have to bother your GP, and we can use all the skills of all the pharmacists. We have enunciated the first ever workforce strategy for the NHS in 2023. It went between 1948 and 2023 without ever having a clear plan for the workforce of Britain's largest employer. It's an amazing thing. So centrally driven reforms. We did a lot of that. And in the NHS, there are also examples of self-improving dynamics. So the internal market reforms of 1991 and also the kind of Blair era, Milburn era reforms, both attempted to do that. So foundation trusts in the health system were all about giving trusts autonomy. So if you made some savings by doing things better, you got to keep them rather than having them snatched away by the centre, right? So you had an incentive to innovate and you kept the resources to innovate. Milburn wanted them to be able to borrow in the open market, but the Treasury said no because they were worried about the risks of that, so they weren't able to go out and borrow in the same way that GPs, the one European part of our health service, can do that. One of the good things about GPs, and one of the reasons why GPs did electronic patient records in the 90s, and the last hospital trust will do them in spring of 2026, is the GPs could just go out and buy it because it's like their money, right? And they have a captive payment that allows them to do that. So autonomy, choice was the other great theme of the internal market and also the Blair era reforms. You would choose and book. If there's a long waiting list at your hospital, you go somewhere else, right? And that's underpinned by payment by results. And we turned off some of that in the pandemic. Rishi Sunak turned it back on again for acute care. I'm sure that West Streeting will turn it back on again for urgent care. So there are those things. And so that's an example of, I mean, one thing that sort of straddles both centrally driven reform and self-improving reform is the importance of performance data, of transparent performance data. And we did a lot to publish more. I put GP performance statistics onto a website called Fingertips, so you can now see in your constituencies where are the good and bad GP surgeries. We did a lot more of that for the secondary care system as well. Weirdly enough, prevention actually already has a lot of it. And that is partly, that data is for lots of different users. It's partly to empower choice where choice exists. And it's partly to give you accountability to the centre, because often as a minister, you're surprised by what the system is not able to tell you about who is doing well and bad, particularly to have very timely and quality data. And it's also to slightly shame people, because people in public services have a mix of motives, right? They have like totally nightly motives. I just want to do a good job. And you meet loads of people like meet GPs who just like work at 100-hour week just to do good service. But you also, there's prestige as well. People want to be seen to do well, and healthy competition through the data is part of the story here. So that is health, and you can think about how those agendas played out in different public services. So in schools, the best example where we did best in the last government, we had both really good and on-target centrally driven reforms. We introduced the phonics check in year 1. We pushed synthetic phonics really hard, and it worked. Michael Gove was really good in terms of unpicking some of the things that stopped us from having discipline in schools, and the endless appeals and legal cases that had every head teacher looking over their shoulder, some of which is brilliant. Phillipson is now reversing, which I think is very foolish. But we also, at least as importantly, created a self-improving system. We got schools to be academies, step 1. Then we really backed multi-academy trusts. So you had groups of schools that were able to repeatedly replicate success, because they've always been miracle schools. They've always been amazing head teachers. But the challenge is to get a group of people at schools who can just repeatedly do that. And with ARC and Harris and multiple others, Judy Grange and the like, they are able to replicate success. And I've seen the benefit of that in my constituency. And I had a failing school that was taken over by one of these really good maths. Incredible turnaround. Brought in a head teacher who's terrifyingly younger than me, and then sorted out the finances, and it's gone literally like done this U-turn towards brilliance. It's just great. A challenge in some of these things is, of course, some of public services, the choice is not an issue. You don't get to choose which council you're in. You don't get to choose which jail you get put in if you get nicked. You don't get to choose which police force you're under. And so the importance of elective accountability is central there. In local government, pretty clear systems, pretty strong accountability. You no good, you get kicked out. We tried to bring in elected accountability for police commissioners. There are some limits to that. I think the jury is a bit out and a bit mixed on that. One of the problems is that you're simultaneously trying to get re-elected, because and the way you do that is to say that the police are doing a brilliant job, but then the other person who's supposed to be holding to account. And previously, there was simpler in a way, because it was local government leaders who were holding the police to account, and their incentive was to say, why haven't you done this? Why haven't you done that? And their incentive to be critical was very different. So I think it wasn't a bad thing. Some police commissioners are excellent, but it's limits to it. So you're going to have to do more top-down things in those public services. And I think, in prisons, there's a lot of things we should have done. We said we would do that we didn't do. Right? We said we'd do new for all. We said it was ridiculous that we still own a large chunk of Wandsworth, which is jolly expensive, and we house dangerous people there. We didn't get around to doing new for all. And the prison service is in many ways pretty uninformed. In policing, we have lots of central levers, because so much of what drives their productivity is the law itself. And we have some things we did that were good, and some things we did, the bail reforms that were more questionable there. So in all these different public services, there's a balance of these centrally driven and kind of self-improving dynamics. We've made more progress in some than others. And I thought it was really good, because it's tempting to think about the performance of public services, but of course, Peel said the success of the police is not about the number of people you arrest, it's about the absence of crime. Of course, a lot of public services, the real success is to get people to not use your public service in the first place. And in that, in health, we did some big things. We're doing the smoking phase out. I think it's a good thing. There's a lot of things we could be doing still, but we're not doing. But I think there is a whole other dimension of it that is so important, like Gabriella's talked about, that I look forward to getting into in the discussion.
Thanks, Bill. I'm now going to hand over to Charlotte Pickles, who's Director of Reform, the think tank that cares so much about reform, they put it above the door.
we endorse the reform fairy, I must say. We'll embrace that. Thank you very much. And as Aveek said, our whole raison d'etre at Reform Think Tank is public services and the functioning of the state. And I think I guess in asking the particular framing of the question of, is there a distinctly conservative approach to public service reform kind of made me slightly go back to basics and think, well, what is the purpose of the state or public services in the minds of Conservatives? And there'll be people in the room, I'm sure, who will disagree with how I would characterise it, perhaps even on the panel. But I thought it might be useful in a very sort of slightly superficial way, just to start with that. And I think there are kind of two big functions that Conservatives would see as key roles or principles, if you like, for public service in the state. One is that the state should be doing only the things that the state can do. And I think we often talk about the state and public services in isolation, as though it's this kind of entity or kind of main pillar that must do everything and solve all our problems. And actually what it should be doing is working in harmony or balance with markets and the private sector and businesses and good employers, etc., but also with civil society and individuals and families, and recognizing that there are distinct benefits from each of those three pillars, and we should be thinking about the state in that context. And there are certain things that obviously only the state can do. I mean, for example, defence and security, but also being, we hope, administratively brilliant at processing certain things. The other thing I think is around creating the conditions for prosperity. And I deliberately say creating the conditions for, because I don't think the state creates prosperity, but I do think it has a very fundamental role to play. And public service in particular, we've heard about health, the importance of health to the wealth of the nation. We've heard Neil talking about some of the education reforms that actually the legacy of the last Conservative or series of Conservative governments is incredibly strong on. These are phenomenally important, but we don't provide them as an end in themselves, right? We provide them because we want people to be able to flourish, we want families to flourish, we want communities to be able to flourish. And I think that's quite important, because actually reform for reform's sake is not, I don't think, what anyone should be here for. We should be here because we have a vision for what we want public services to achieve, and we need to think about, therefore, the best way to deliver them. And I think if you were to take those two sort of principles, if you like, of what perhaps Conservatives, I'll put it that way, might think the role of public services are, I think that also then leads to two things around reform. And Neil, as I would expect, put brilliantly the different types of reform. So perhaps I can just sort of build on that slightly. The first around do only the things that state can do. So those things, and by that I mean the state needs to deliver those things very directly. And that's where I think we need to be focusing on those reforms, which are about driving efficiency, value for money, and that has to be seen in the long term rather than the kind of short term, which might get you a penny saved here and it's going to cost you a lot of pounds down the line. It means you have to care deeply about the quality of management, which requires management information, but it also requires you to think about the processes and designing the way things flow through a system. And so there's a whole host of things which will mean that you'll have much more efficient, effective services for the bits that the state must do. And that's everything, as I say, from procuring defence, which we're pretty awful at in this country, through to which actually is now a really, really big success story in processing passports and DVLA licenses and stuff. So I think that's really clear. And then I think on the other side, if it's about creating the conditions for individuals and families and communities to flourish, then it strikes me as being obvious that you need to allow them to make more of the decisions and be part of the design of the services, so that what you have in terms of public services is actually meeting the needs of the people you're serving. And I sometimes think we forget that public services are serving people, right? And we tend to focus much more on the kind of provider than we do the consumer of those services. And we don't, or we haven't always built healthcare, schools, take your pick, around the users of those services. We've actually done some of the reforms which are much more focused on the provider, and they don't always have better outcomes for those who are using them. And so I think there's something in then the sort of subsidiarity principle, and that's why over the last however many years, decade, I guess, by the time we got to it, the devolution agenda has been really powerful. And we heard about the importance of delivering health in a community environment, because actually the people who need to have the additional support know best what that support should look like. And I think that should be a very fundamental Conservative principle, actually, and it links to this idea of choice. But actually you can't have that, I don't think, or at least maybe people will disagree with me. I don't think there's many people who genuinely think that a bureaucrat sitting in Whitehall is going to be able to make a better decision about what that ward level, public health intervention should look like, or what that particular school with this type of demographic should be doing in it. And it links to the autonomy, it links to the choice, it links to those sorts of things, which I think are fundamentally conservative principles when we think about reform. And they are about putting, as I say, individuals, families and communities in the driving seat. So just to kind of finish up, what does that mean in practice? So I think it means shrinking the centre, and it means building capacity in local areas. But I don't think it just means building capacity in terms of the state doing everything in those local areas. There will be, civil society organisations that can do far better job, particularly around the relational stuff. The state is not good at building relationships. So why do we think it should be state apparatus that is doing that? Why wouldn't we say, yes, of course we need to provide these services, but there are better organisations that are not state run that could be delivering them? I think it means that we do need to rethink some of the traditional institutions and ways of delivering stuff. So, schools, hospitals, GPs, they all look pretty similar to, 75 years ago in terms of the NHS, or, longer for schools. Like, we're not being as creative as we could be. We're still thinking about four walls and what goes on in four walls, rather than thinking more creatively and innovatively about how we deliver those public services where people need them. I think it also means thinking about how money is flowing through the system. And it of course is a truism that you do need more investment in certain areas. Social care is the most classic example of that. It's also true that there's a hell of a lot of waste still in a lot of services. And in fact, you could go to any part of public services and people working in them will give you the examples of where they don't think that the system is efficient. So think about how that money actually goes from central through government through to delivery on the ground. I think we could find quite a lot of capacity to be able to reinvest some of that money. And then I do think, as I say, it's thinking about things like the application of tech. We've already had good examples of that, as well as the application of really high class management. It's never popular to talk about more managers in anything, but actually, conservatives in any other part of the world, you talk about business, we would think about the importance of great managers, and yet you talk about in public services and suddenly the managers are the bad guys. And actually I think we need to flip that on its head, because we would get vastly better performance, particularly in places like the NHS, if we took management much more seriously.
Just say on behalf of the SMF, we're very happy to start talking about management.
This is true. I think in general, I'm quite happy talking about it. It's others, yeah.
Brilliant. So finally, I'm going to move on to Dr. Michael Spence, who is President and Provost of University College London, and before that was Vice Chancellor of the University of Sydney. So we'll look at universities and how they fit into the broader picture of public service reform.
Sure, look, thank you very much. I think this debate between the central and the local is, apart from being perennial, often missing a sort of third leg. So the assumption is that local communities have a huge amount of local understanding and local knowledge, and therefore the ability to think about what's going to work in our context. And the centre has a particular capacity to do economies of scale, a particular access to technology, particular access to global expertise, all the rest of it. And that's true, but what's also really important is a capacity to innovate. And the question is, how do you get the capacity to innovate? How do you equip local communities with the capacity to innovate so that they can bring that together with their deep local understanding to think about what might actually work? If you live near UCL, you're incredibly lucky. The former leader of Camden Council, Georgia Gould, said in my first week of the job, we could not do the work that we do in Camden, but for UCL, because we're McKinsey's without a price tag. We do all of this research for our local borough. We do all our this research for the borough of Newham, which is incidentally the most deprived in the country, where we have our UCL East campus around everything from traffic flow to air quality, to the delivery of services. You might live near our legal advice and social referring centre. You might be able to take advantage of the work we did with Moorfields Hospital in early diagnostics in the Brent Cross Shopping Centre. You might have been benefited from the work that we're doing in situ prostate diagnostics early, building on the work, the technology-enabled work that we did with MRIs to avoid to avoid biopsies, where the former treatment was PSA, or diagnostics was PSA uncomfortable biopsy, and we were able to show that with an MRI you could get the same effectiveness in diagnostics. Now we're working with the private sector, so the 40-minute diagnostic actually becomes a 5-minute diagnostic MRI, and with portable machines, so that too will go into shopping centres. It's great if you can do all that kind of local, high-tech, innovation-informed a development of services. But you can't do that everywhere in the country unless you have access to that kind of innovation capacity, and not all communities do. And so the work of which I am particularly proud is the work we're doing right around the country, and indeed right around the world, with local communities, like the work we're doing in Bradford in early intervention, or like the work that we're doing in the backyard of another Russell Group university. I won't talk about the locality, where the local community doesn't want to work with the local Russell Group university because they have such complex relationships with the local university precisely because of local politics, and instead would prefer to work with the university from London with a certain amount of distance. I think what I'm trying to say is, actually, if you're going to empower local communities, or I could talk to you about the work that we've done in co-creation of services reform through our Institute for Global Prosperity. If you're going to empower local communities with the kind of understanding about what might be available in the best technology, in the newest technology, and equip them with the capacity to think through what services reform looks like and what models there might be, you need to think about how you make sure that innovation centres like university are working effectively in networks and with communities across the country, and not just in one particular place. And that's often counter to universities that want to have their patch. And it's often counter to the thinking of people involved in public services reform, who tend just to think about the centre or community groups, or the centre or industry. That said, we are beginning to think in our local environment about, and to work with our local ICB and with our 5 partner hospital trusts to think about what a healthcare system for an ageing population with multiple comorbidities that isn't quite so doctor-centric and hospital-centric, given that we know that the doctor-centric, hospital-centric model has kind of reached the end of its clinical efficacy and certainly of its affordability. We're beginning to think about models there that we hope might be scalable and replicable. So for me, it's how you empower local communities, but also make sure that that rich network of new ideas is available across the country.
Thank you. I'm going to kick us off with a question, but I'll come to the audience in a moment to do think through your sharpest and most penetrating questions for the panel. I think the thing that I'd like to pick up on, so I think there's a lot of stuff here which is quite technocratic, for want of a better word, that would be just acceptable to either side. I'm really interested in this question of what is distinctively conservative here. And there was a bit of a thing between Gabriella and Neil's contribution. Neil brought in the idea of motivations, or different kind of models, essentially, of public servants, where I think the left traditionally is a bit more trusting of public servants, more willing to defer to professional judgment, more likely to see them as knights, as Julie McGrawn's phrase, right, that Neil picked up. And the right maybe is more suspicious, more likely to see things through the lens of rational actors, and more likely to get into the kind of conversation around incentives. So to what extent do you think there is a distinction between the left and the right's kind of conception of public servants? And on the side of public service users, do they have different conceptions between consumerized rational agents and maybe passive recipients, if we're putting those in group terms? Gabriella, do you want to come in on?
Sure. That's an interesting debate. I mean, to be honest, I don't believe much in distinction left versus right. I believe to achieve a certain objective, like how do we want to improve the health of the population, and what's the more cost-effective way of achieving so. Now, the approach that I talked about, as I said, it can have some, conservative perspective for the reason that I said. It's top-down, it fosters public engagement, resilience, and it puts emphasis on personal responsibility. Now, from the point of view of an economist, then what we think about, well, we think that individuals act or try to act in their own interest, so what we say maximize their utility, the well-being, but they are subject to certain constraints. And which are these constraints? Well, there could be economic constraints, they don't have the money. There could be time constraints, they don't have the time, they don't have the information. There is no supply of public services available. So to the extent that we try to act on these constraints, like providing incentives to relieve these constraints so that individuals can achieve optimal behavior toward the target that we all want to ultimately achieve, like improving better health, then I don't think that it matters whether the means through which we achieve that are for left or of right. So I think what we are to focus on is what is our outcome that we want to achieve, and what's the best way, like could be a cost-effective way of achieving it. And the approach that I mentioned is one which I believe is very effective. It's proved to be an effective approach to achieve this aim.
Thanks. Neil, is this a debate beyond left and right?
Sort of, but sort of not. I mean, I think that the right are intuitively much happier with testing and publishing data and things like that. So in schools, we like kind of testing, and we think it's important to raise the performance, have nice simple data people can understand them. And we like to then say, oh, look, why with the same resources and the same cohort of kids coming in, why is this school better than this one? And then how do we act on that? And the left are intrinsically more inclined to say, oh no, this data, it's incomplete and it's not fair and it's stressful for the kids, it's stressful for the teachers, and to think about the producer interest a little bit more and to query the data. So the same is true in loads of different domains. So in LEO, the longitudinal educational outcomes, a lot of the HE sector don't like that data. I like it a lot because it is telling you about the earnings of those who've done different courses at different universities. And it makes you ask a difficult question. It's like, we are spending huge amounts of taxpayers' money the value degrees in the sector, then say, oh, well, hang on a minute, it's not quite fair because some of our graduates might be more likely to go to live in a poorer area, and there's perfectly reasonable quibbles to the data, but they fundamentally don't have the same enthusiasm about its creation. And the same is true. Local government is a really good example of where two different instincts on the right side coincide. Our intention. So Michael Gove created OFLOG, which is the Office for Local Government, which just gives you basic data on the performance of local government and the financial health of different local government. There's quite a lot of controversy around that because people worried it was bringing back a thing called the Audit Commission from, which everyone remembers from the Blair era. And we got rid of the Audit Commission because we were worried it was way intrusive, it was asking for far too much information, it was trying to micromanage local government. And to come back to your question, so everyone in this room probably does remember this Julian undergrads distinction between knights and knaves and pawns and queens. Do you think people in public service are all knights who want to do the right thing, they just got the right intrinsic motivation, you just got to set them free? Do you think they're all knaves, they're all bad people, they just want to put their feet up if you give them half a chance, you need to be constantly thrashing the system? Do you worry that they're all just pawns who you've infantilized, you try and run the education system by endless initiatives from DFE towers rather than giving them freedom to get on, which are queens who are powerful, who can actually innovate and give them the freedom to do things. And in local government, we worried that we'd sort of tried to micromanage local government and go too far, but then Michael wanted to course correct in 2022 or something. He said, well, wait a minute, at the moment there's now no data at all on local government. So voters, the people who've got the only way of bringing accountability to the system, can't make an informed decision. And maybe one of the sharpest versions of that tension is about local government finance. So there's a technocratic bit of this, which is the local government finance formula is just beyond broken. The variables it contains include the amount of snow that fell in 1978. Okay, this is a broken formula. It's got lots of old data in it. There's a superb report by the former head of finance at Leicestershire on this exact issue by Chris Tandini. So it's broken in lots of ways, but it's also, it stops there being proper accountability in local government, because I don't think many voters have confidence that the financial performance or performance of their council is just really about their own local politicians. If you're in Wandsworth and Westminster, do you think you've got council tax that's super low just because your councillors are abnormally brilliant? Obviously not, right? The formula is just giving them this incredible advantage. And so people then can't have confidence that there is a fair foundation where everyone, according to their the needs of their local population, has a reasonable shake of the sauce bottle, and that the performance variation you then see reflects the performance variation of the local council. Until we get to a rational and non-broken funding formula, it's quite difficult to make local democracy work. And that's then one reason why central government then massively clips wings of local government and has caps on the amount you can raise in council tax, because we worry that local councils would just blame the government, plausibly, and then massively raise tax and do a bad job of it. So unless you can get to confidence in a self-improving system, then you don't, the centre won't let go and won't give councillors the freedom to do the things they need to do. And the result is great dissatisfaction in lots of ways.
So I think on the question around those working in, so what is the distinction between left and right? I think that and let's caricature it for making the point. I think the left thinks that the state in and of itself is an important thing, and that the state should be delivering most of the things people need, and the state can indeed solve most of the problems. And I don't think that is what most conservatives think. So if you're starting from that point, then I think you're naturally going to have a different perspective on both users and what you're trying to achieve via the role of the state, but also then in terms of those who work in it. And I wrote down exactly Neil's made the point, so I'm not going to dwell on it, but I wrote down, data and transparency, because I don't think it is a matter of trust or not trusting people who work in public services, but I think it's about the way you're applying your trust. So, it's hard, I think it'd be very hard to argue actually that the right doesn't trust people working in public services, given, for example, the Academies programme, given actually the land use reforms were not a good thing, but, the idea was to give clinicians far more power and to be able to decide, right? So actually, if you looked at actions, which is clearly where that normally tells you how people feel and what they care about, actually the action has been to empower and give greater autonomy to those working in state. But the flip side of that is the accountability point, and Neil made that very well, which is that Conservatives do want to publish the data, they do want you to be able to compare, and I don't think that's comfortable, that's something that people on the left are comfortable with. I think some of the stuff around Ofsted could be deeply damaging, actually, particularly to disadvantaged children that we're seeing coming from the current government. I think on the point around how you see users, there is a part of the left that definitely does have a much more paternalistic approach, and that I think links into the state can solve the things. If we just, we had a great thing. I was at a different think tank years ago, the Centre for Social Justice, and we did some work looking at some of the welfare reforms under Brown, and we used the phrase "it's poverty plus a pound," and I think that kind of captures one of the approaches you sometimes see with the left, which is that we are innately doing a good thing because we're giving a bit more money to this group of people, and that is solving the problem, right? You're not in poverty now because you're a pound above the poverty line. But I think that what we did, and when I went into government with Ian Duncan Smith into did the welfare reforms, we've got our kind of rationale was the system should be making work pay, because the best route out of poverty is well paid work, and that's why we also want to think of public service reforms in terms of progression in work. And so I think I think perhaps there's a distinction between being the kind of use the word passive, but sort of, yes, there's a kind of paternalistic, you know, we're doing the good thing by giving people something. And, you know, certainly from our perspective, when we were doing those early welfare reforms in the coalition, it was we're doing a good thing by helping people not need the welfare system, right? And that I think is part of the distinction between left and right. Though I would say I think it's very blurred now. And if you listen to some of the stuff that the current government is doing, you know, you listen to Wes Streeting about some of the reforms, you know, you listen to this Kendall about some of the stuff they want to do. I think that is blurring. I think that's a challenge for the Conservatives then, in terms of how you position yourself as different in a world where, you know, some of the Labour rhetoric, not all of it, I again agree with Neil, I think the education stuff broadly looks horrendous. But I think in some other areas, actually, the distinction is blurring.
So I think in most problems, both intellectual and practical, the middle is the really hard bit, right? Everybody can point to terrific local examples of something really working. And everybody can see what you would like the whole system to look like. But it's getting the middle right that is really difficult. Getting and I think that comes to a question of attitude in the public service. Is the orientation of the public service to empower the local and to think about the scalable, to experiment with what might work at the local level, and then ask ourselves the question, how do you have systems nationally that support that empowerment, but also systems that scale things that are going to be a broader application? So we're not just we are a nation, not just a federation of local communities. Or do you start with a sort of tabula rasa and design the perfect system and then try and impose it on local communities? And so for me, it's not about whether you like public servants or don't like public servants. It's the ethos that you grow in the public service, and whether or not that ethos is able to, whether or not the public service has an orientation towards telling people what to do, or an orientation towards empowering and scaling the local. And that seems to me to be a fundamental difference between the left and the right, where the left is more inclined to tell people what they should be and want and do, and the right is more open to the notion of the local growing.
Good. Got time for a few questions. So who wants to jump in? Yourself there.
Yeah. It's 3 questions, really. First one is, where do you stand on schools providing breakfasts for kids in Quad? Seems to be quite an interesting debate at the moment. One's for Gabriella, where would you draw the limits of the state, really, Gabriella? Or do you think that whoever works is a good idea, basically, which is a rational position? But where would you draw the limits of what the state does? And for all of you, are you just worried about, or are you trying to do the wrong things better, more efficient?
Lady there.
I'm Rachel from Action Children. I was really sort of Charlotte's points around talking to and engaging with service users or people who use those services and public services. So the Children's Trust Commission talking about engaging with young people in the development of those services. It's been really difficult to get the government out there proposal for that. How should you see that kind of engagement between the users of the services and designers of the services?
And one more.
Yeah. My name's Amy Williams. I work in the NHS as the Divisional Director of Operations. I'm really interested in your views on how we improve management. I guess my question really is around how do we, as Conservatives, I've been, in my role since we've got the Labour government, shocked at how much we've suddenly begun privately insourcing and outsourcing. I've signed something in the line of £5 million worth of activity to happen over the next 3 months. How do we as Conservatives sell to the public the fact that we are the party to protect our national institution, and how do we go about proving to people that Labour aren't the great benefactors of our NHS that they would like, that in fact people do think they are?
I'll move along the panels. I'll start again with Gabriella.
Yeah, so thanks very much for the question about breakfast, which allows me to talk about the importance of nutrition and diet, which I'm a huge believer on, is a huge important input in the production of health. And all the work that I've done, where we're touched not only about like breakfast, but in general providing good nutrition to children, has shown the importance of nutrition, especially in the first year of life, starting, I would say, during pregnancy, if not preconception, for life chances. Now, I want to make a key point about who is providing what. I think the key thing is to have an optimal level of what we call inputs, like investment, things like nutrition and healthcare. Then who's providing them depends a little bit on what would be the alternative. Now, if I have a poor parent who either for lack of money or time, the constraints I was talking about before, is unable to provide for the children, then someone, should do in his place. Because at the end of the day, what the child is gonna have, well, it's not gonna have, that provided, say, by the state or by the school, is gonna have that provided by the parent, and whatever, level is low, that's gonna affect the child development. So the importance of a counterfactual is really key. And there are several examples. I know the school breakfast program has been shown to have important impacts on the academic achievement of the child. There are several other examples internationally. One particular example I'm really fond of is an early program in Italy called the Reggio Approach to Early Childhood Education, where children are provided nutritious food in school, where breakfast and lunch cooked in the kitchens of the school, so children can also appreciate to have really healthy, especially a lot of fruit and vegetables. And let me go a little bit further to talk about another particular program, which I think is really important and could really do with a little bit of push, in this case from the state. It's the Healthy Start voucher. And that's essentially vouchers that provided, they're being tested to, let's say, low-income women to provide healthy food, in particular fruit and vegetables. And we are working, we have a project on these Healthy Star vouchers. And let me just tell you that as compared to what happens in other countries, especially in the United States, both the amount of money which is provided, but also not only the take-up, the eligibility to this program is what I would think is a bit below what would be an optimal level. So in that case, if parents could afford, then we should really understand why, what are the constraints, and then we should do something to release the constraints and provide incentives to improve the inputs in the child. Because as I say it, and I keep saying it, improving health means improving our society and our economy. So thanks for asking the question.
Yeah. So on the question about service users, there's lots of different domains where we could listen more and learn from that. I particularly always think of those who've been diagnosed with either Parkinson's or Alzheimer's, and I think the NHS is really poor at providing them with a clear plan. A lot of them are left with a sense that they have no idea what they're supposed to do next. Even if there was just a clear plan. There should be a standard where you get some kind of pack, you get connected up with some sort of local services and a clear sense of what you're going to do, and that isn't there a lot of the time at the moment. And there's lots of things where you wouldn't think of them as public service users, where you can learn a lot from just studying people in a group. A really extreme example of that is people who leave prison. One of the things I was working on as a health minister was about the transition from drug treatment in prisons to drug treatment in the community, which is very, very, very broken. And a lot of people who are on treatment in prison then never turn up at their supposed treatment centre in the community. And so just understanding all those pathways and why they don't and stuff like that. Everyone knows that the handover as people leave prison is very poor, and people leave and have nowhere to go, and they get released. There's lots of things to fix anyway, straightforwardly. On the big question about how can we do better than Labour on the NHS? So I think there's lots of different potential ways into that. One thing I've said before, and will repeat here, is I think for us, one of the reasons we got kicked out, it's very clear to me, is the NHS, and people were really unhappy with it. And I got that. Talked about 7,000 people during the election, and I got that a lot. And it's a big problem. We can't get back in until we address it. And we did a lot of positive things in the NHS, and we obviously spent record amounts of money. We put in 30,000 extra nurses. 6,000 extra nurses, 30,000 doctors. We hit a lot of our manifesto targets. We really did deliver 50 million more GP appointments. We really did hit all of our nurse recruitment targets. People didn't feel the benefit because of the pounding effect of our demographics, which I think is going to take Labour by surprise, because they still think it's like in the 90s they came in, they had loads of money, and then the demographics of the 90s. Two facts. if we had the same population structure that we had in 2004, 20 years ago, the Chancellor right now could spend the same amount for every age group, the same service, and have £84 billion left over, which is the same as being able to cut the basic rate of tax by 13p in the pound, right? That's the power of demographics for you. That's just 20 years. Another way of framing it, I remember from being in public health, in primary care, there's a third more people over the age of 70 now than there were in 2010, a third more. They have 5 times more GP appointments each than a young working age person. And so funnily enough, you can increase the number of GP appointments by 50 million. That's 44 more appointments at every surgery, every day. And people don't feel the benefit because they're still not able to get through. Now, we tried to be quite targeted. We did the investment in technology, make it easier to contact your GP. We took the load off with the pharmacy stuff. But some of these things Wes is going to find, Wes is no fool, are hard to shift. And he's going to get a ton more money, in the budget. I'm sure that they're going to relax the borrowing rules. They're going to do some treasury magic. You're going to find you're on GGGD rather than PSND. You're going to find the Bank of England's debt has been reclassified. There could be some complicated stuff that you don't need to, the journalists will not be able to unpick, but they're going to borrow a lot more money and they're going to spend a little bit on the NHS. And so Wes's life will be easier in that sense, but it won't be easy in another because the demographics are just so unfavourable now. And I think that there are certain ideas that are very attractive to the public, and one of them that Wes seized on was the idea of bringing back the family doctor. And a posh or technocratic version of that is continuity of care. There's good clinical evidence that if you see, particularly if you're an older person, you see the same clinician again and again, it's better for your health because you're more likely to notice a change in your condition, blah, blah, blah. You don't have to repeat your life story every time. Achieving that, you don't need masses more resources, but you do need some because, of course, demand goes up and down. And the reason why Labour got rid of the individual patient list for GPs in 2004 was that in some ways it's more rational, right? You just see who the first clinician is that's available. And you need more, if you want to unwind that, you need some more resources. I'm very attracted to trying to bring that back for older people in particular. That does have some resource implications that we need to find within the system some more resources. I'm also quite drawn to a thing that's had many names in the NHS. It was called fund holding in 1991. It's called primary care, home more recently, practice-based commissioning in the 90s. But broadly speaking, is the idea that you put more of the budget in the hands of the GPs. Why do you do that? One, there is this incredible sucking force in the NHS. All the money is always being pulled into hospitals. They have the prestige, they have the urgency. We said in 2019 we'll change the share of the budget more towards primary care. But then the pandemic hit us and we found ourselves putting loads more money into acute care and trusts. It's always this sucking sound. So unless you do something big to empower the GPs, all the money is always sucked into much more expensive hospital care rather than them having the power to pull it out of the hospitals. I want, in my own constituency, us to be able to get more services out of Leicester Royal Infirmary, not only an expensive place to do care, but also extremely difficult to get into. It's a big island, you drive around it hundreds of times before you get in. And I want those services to be in the little Scottish hospital in Market Harborough or in Oadby or wherever it might be. But that won't happen because the clinicians who've got that budget at the moment are not going to release it. And so unless you put the increase into GPs, it won't change it. Also, the GPs had a second role in fund holding, and Julian and Grant and other people, including people on the left, agree that this was working, that they are the shopper on your behalf. One of the problems, the difference between health and education is people kind of feel like they know what a good school is. And you can see in the league tables, the results, even performance, the value added, the sophisticated measures that the parent can make a choice. It's quite straightforward. If your GP tells you you need siloxaban rather than filopilal or fibromal, you're in no position to judge really. And health has more asymmetry of information. So the GPs in fund holding were able to do that for you, and they're able to say, I'm not getting that. This person is not being given the urgency of treatment that they deserve. By the way, hold your budget. You need to pull your finger out in the hospital. And so they became powerful advocates for you. Because we've talked so far about public services as if they're a single thing, but often there are competing tensions within them. There's different bits of them, and you want to figure out the relationship between them. And so I am drawn to a return to the family doctor that would have two parts: one, continuity of care and patient experience, and two, the empowerment of GPs, which are the one little European part of the NHS, the bit that's for profit. People have autonomy; they can do their own thing. They don't have to wait for someone in Whitehall to sign off what they do. And so I think one of our stories could be about bringing back the family doctor. There are many others, but that'll be one of them to pick on.
Great, thanks. We're almost at time, so I'm just going to give a couple minutes each, just to wrap up.
Couple minutes each to solve the NHS.
You're ticking clock as you speak.
Exactly.
We can dramatically tick down.
Exactly. So just very briefly on the free school meals, which I think was kind of the implication. So should we have universal free breakfast? No, but we should do targeted stuff. But if you have finite resources, it's ludicrous to spend a load of it on wealthy people who can do it themselves. And I think that's harmful. On the kind of how do you do things differently in the NHS, the problem, so Neil is right about all those great things. The problem is actually that if you look at what happened, there's vastly more doctors in hospitals. We didn't really increase GP numbers. We just got them doing more appointments. And we didn't do anything about district nurses. We didn't do anything about social care. We didn't do anything really about health visitors. All those have gone down the other direction, which is all of your preventative upstream stuff. So actually thinking about the workforce is going to require some decisions. We have seen a massive specialisation, like a kind of increasing specialisation in hospitals around doctors. People don't want to become GPs. They don't want to go into, nurses don't want to go into district nursing. They want to go into acute. There's a whole set of workforce things that you'd need to think through. We, on the kind of pooling of budgets, absolutely, but you need to pull the whole frickin' thing, right? So we published a paper called Close Enough to Care a few months back, which literally says, scrap NHS England, abolish it, like you've got too much at the centre. Thank you. Do you know what, that is the most common response. Sorry. So you'll be fine.
You say whether you agreed or not.
Yeah, exactly. You might work it. You might be working on one of the bits that we said should go back into DH. So, but anyway. But we said you need to devolve the entirety of the NHS budget to regions, which is your middle tier that we haven't talked about. But you need to not just give GPs like more of a fund, you need to combine all of the different parts of the funding system. But we laid out a whole model of how you would do that. So all I'm going to say, rather than going into it, as Aveek was very clear, that was long, is go and read Close Enough to Care, because that exactly talks about why actually it's the flow of the funding which is your biggest barrier, and we didn't, Conservatives didn't do anything about that, and that would make a massive difference of shifting things.
And Michael,
so in reverse order, the regions are really important, which is why. So I sit on a hospital board that's about to take over another hospital, having taken over another hospital, and all the rest of it. And we are essentially reconstructing regions. We're just doing it in a kind of haphazard way.
But not with local government, and that's the problem.
Exactly.
That is the problem.
And a part of the problem of the NHS at the moment is there's no space to sandbox. So there's no space for integrated care boards really to do the kind of thing that they were designed to do. They're just passing through budget and creaming off a little bit for innovation.
And reporting it to NHS England.
Reporting it to NHS England. Whereas if you could have, so there is there are real possibilities for a different story about what the NHS might look like. On the consultation with young people thing, could not agree more. I have 8 children for my sins, ranging from 5 to 32. There is a huge generational break between about 20 and 25 that we have a particular expertise of work in adolescent psychology. And it is true that the needs of young people have dramatically, and desires of young people have dramatically shifted, and not enough social services are engaging with young people and listening to them in the way that they need to be at the moment. Interestingly, the public gets this. So we have a whole program in Disagreeing Well. We're about to have an event in Disagreeing Well across the generations. We've closed the registration at 1,000. And we've closed the registration at 1,000 because the response was just overwhelming. The community wants to talk about how you talk to young people in a different kind of way. On the free school meals point on the breakfast, targeted intervention is obviously right, but the right doesn't believe in infantilizing adults. The kind of work we were talking about before and the kind of work we do with Enact Early shows that actually infantilizing infants has a lot to be said for it. But as a governor of a local school, the one my children attend, that has a very large disadvantaged population, ironically, the problem is getting people to take free school meals, because for us, the big issue is that people come to school with 3 packets of chips and a chocolate bar, and they have that and opt out of their free school meals. Early intervention is crucial, but early intervention is actually very socially complex, and that's why local communities really need to be empowered in that space.
Great note to end on. So sorry for running a little bit over, but thanks so much for your patience. Thanks for your attentiveness. Thanks for the great questions. I hope you join me in thanking the panelists for some brilliant and very thought-provoking contributions. Sorry we didn't solve it in an hour.
We didn't
But a lot more details. And as a sort of final event, do join me in thanking the wonderful NHF, the wonderful SMF event.
Clap for think tank.
The wonderful SMF team for putting on some brilliant events over the last 3 weeks. So thanks to you. Enjoy the rest of your conference.
Okay.